Good evening, all. I hope you can hear me.
Yes.
And okay, hello, Dr. Najdecki. It's nice to see you. Welcome all to our live event. Our topic today is implantation problems and solutions worth considering. And yet again, we will hear more on patient cases. Our special guest today is Dr. Robert Najdecki, who's already has been conducting one of our past webinars. He is the scientific director of Assisting Nature, which is located in Greece, Thessaloniki. And let me again remind you about some rules. We will start the presentation and the presentation will take 20 to 25 minutes, and our Q&A session will follow right after. Again, let me remind you that this live event is being recorded and you will be able to see it tomorrow on our site. You can see the link in our chat section. And of course, remember to ask your questions on our chat section. And of course, I hope you will enjoy it, and I believe we can begin. Dr. Robert, are you ready to start?
Thank you, Caroline, for your pleasant introduction. Dear friends, ladies and gentlemen, good evening and welcome to our webinar. I feel really honored to be invited by the organizers, Egg Donation Friends and IVF Media, and to have the opportunity to exchange my experience and knowledge with you. Working and speaking with professionals is an everyday practice, but discussing with patients about their interests, it's a very important and valuable goal. Let's start. Nowadays, despite the scientific progress and human reproduction knowledge developing, the process of embryo implantation in human uterus remained the post-undiscovered part of the whole process of pregnancy. The term implantation failure can be used to describe patients who have never shown increased level of HCG or without later ultrasound evidence of a gestational sac. Implantation failure can apply to patients undergoing assisted reproductive technology and patients trying to conceive without any fertility treatment. Repeated implantation failure refers to a situation when transferred embryos repeatedly fail to implant despite numerous attempts via assisted reproduction technology. The implantation process after ART depends on many complex factors: uterus cavity environment, embryo's quality and euploidity, high performance of embryo transfer procedure, and of course others. Our first real case: woman age 36, healthy, spontaneous conception twice, both miscarriages. First 2 blastocysts transfer without pregnancy. Normal hysterosalpingography and uterus ultrasound scans. Despite these facts, we decided to perform the diagnostic hysteroscopy to check the uterus cavity and exclude every possibility of anatomical considerations. What we found: partially septate uterus without any previous ultrasound diagnosed signs of septum. And what have we done? Hysteroscopic septum excision with scissor scratching. Afterward, we decide to perform in the next cycle the second embryo transfer. 2 blastocysts were transferred with a positive results and resulted in live birth of 2 healthy children. Big congenital abnormalities, polyps, fibromas, are very well known, and their negative influence in the implantation process is statistically confirmed. But smaller anatomical variations are expressing different degrees of uterine and endometrial dysfunction. Their influence in the implantation process is probably under-investigated, partially unknown, and underestimated. Besides the anatomical and structural effects, endometrial scratching or scratch injury is an intervention leading to enhanced endometrial receptivity by some other mechanisms, such as inflammatory reaction, better synchronization of endometrium, and inducing decidualization. Our real case 2. Woman age 35, healthy, MAH under 0.1 nanograms per milliliter, FSH high, 32, LH high, 37. One attempt of 2 blastocysts that were transferred after egg donation in another unit with a negative result. We decided to start the exclusive egg donation program, all eggs guaranteed, with prenatal genetic testing in our unit. The husband's sperm was severe oligoastenospermic. We collect 13 eggs and 12 eggs was used to fertilization. 11 eggs fertilized, 6 blastocysts achieved. But after prenatal genetic testing with NGS, next generation sequencing, only 2 blastocysts were euploid. Eggs are not the same. Some eggs are better than others. What does it depend on? Of course, quality of donor, stimulation protocols, drugs. The way from oocyte to blastocysts is not always easy and predetermined. Not all oocytes become blastocysts. To understand it, we use the term blastulation rate. It is the percentage of the fertilized oocytes which become 5th-day embryos, blastocysts. If we have the blastulation rate about 50% or higher in our lab, which is a very, very good result, and this is realistic, it means that from 6 oocytes used, at least 3 will reach the blastocyst stage. But what about the sperm? The sperm is not the same in every case. Sperm morphology, unfortunately, day after day falls down. What is the reasons? Emotional stress, smoking, drinking alcohol, being overweight, exposure to environmental toxins, having past or present infections, overheating the testes, aging, having medical conditions including tumors and chronic illnesses, taking medication or undergoing medical treatment such as radiation or X-rays for cancer. And continuing with this case, performed single euploid blastocyst transfer. After 10 days, we had positive results and live birth boy 3,200 grams. And this woman has another euploid blastocyst vitrified in our bank. At Assisting Nature, we try to create an ideal personalized donation program. Using euploid blastocyst, we significantly increase pregnancy rate over 60% per embryo transfer. Real case 3. Healthy woman, 33 years old, regular cycle. One attempt with 2 euploid blastocysts transfer after egg donation program in our unit with negative results. We decided to perform diagnostic hysteroscopy with scissor scratching and proceed into the next transfer 2 months later. We didn't find any visible anatomical malformations during the hysteroscopy. What have we done? We still perform hysteroscopic scissor scratching. Euploid blastocysts plus hysteroscopic scratching plus enhancing endometrial receptivity by inducing desudalization through inflammatory reaction leads to live birth, boy 2,760 grams. It was double euploid blastocyst transfer. As we see here, the normal egg donation programs have over 50% pregnancy rate, but adding the euploid blastocyst transfer, we achieve about 10% pregnancy rate more. And adding hysteroscopy scratching, we achieve another 10% in pregnancy rate. And then we are talking about 70% pregnancy rate after first embryo transfer. This is very significant, and it's not cumulative pregnancy rate. It's a pregnancy rate by first ET. Of course, we have other mechanisms of recurrent implantation failure. Natural killer cells were given their names because of their ability to kill leukemic cell lines. Uterine natural killer cells are derived from the NK cells line due to their CD56 plus marker. They are the dominant immune cell types in the mucosa of the uterus and have been suggested to play a role in trophoblast invasion and increased spiral artery blood flow. In many studies that both peripheral NK cells and uterine NK cells are elevated in patients with recurrent implantation failure, NK cells level and activity is just one aspect of the immune system involved in women suffering from infertility. Several autoimmune antibodies, such as anti-nuclear antibodies, anti-cardiolipin antibodies, and antiphospholipid antibodies, are involved in biochemical pregnancy loss. Some data is suggesting that hereditary thrombophilias may be involved in a subgroup of women with unexplained recurrent implantation failure. What we have and what we use, of course, we have an immunosuppressive medicines like corticosteroid and are currently approved for immunological therapies used to increase rates of implantation. Also, antithrombotic agents, heparin, has been evaluated for the use in recurrent implantation failure patients, though there is not yet evidence to recommend its use for improved pregnancy outcomes in these patients. Implantation relies on crosstalk between the embryo and the endometrium, with facilitation by many different factors, such as growth factors, cytokines, cell adhesions molecules, and transcription factors. One of the possible mechanisms involved in recurrent implantation failure is the change in endometrial receptivity. One of the changes in receptivity might involve the shift in timing of the window of implantation. Endometrial receptivity array area test is used to identify the window of implantation changes based on 238 genes. And our conclusion. Recurrent implantation failure is a complex problem with a wide variety of etiologies and mechanisms, as well as treatment options. The recommendations for women with recurrent implantation failure vary depending on the source of their problem. Perhaps the best and the yet most complex answer is personalized medicine, a personal approach to each patient, depending on her unique set of characteristics. Bringing all together, adding prenatal genetic testing and hysteroscopic scratching to an egg donation cycles seems to bring the highest possible results, and it is a state-of-the-art procedure and a tailor-made approach to one patient's need. Then, supporting endometrial preparation and luteal phase by using antithrombotic agents, immunosuppressive drugs, intralipid infusions, we achieve the best uterus environment for embryos implantation. Thank you very much.